fine, 1:30. All right, so the floor is open, please. Would you kindly go to the microphone and identify yourself so that we also know who you are?
This is Alison Chaikin from HP. I believe Professor Odysseus mentioned using NMR for pre-symptomatic diagnosis. That seems to be a puzzlement since NMR is a big piece of capital equipment that has to be scheduled a long time in advance. So that must not be the ultimate plan for that research for pre-symptomatic diagnosis, I would think.
Can you speak to the microphone, please? Fellows, be there. Okay, desk mic. Yeah, you should be able to speak.
I'll take this one.
Okay.
Well, that would obviously be an expensive way of diagnosing inflammation, and we would prefer to have other non-invasive approaches for detecting inflammation. So that's what we're hoping to get feedback from people at CITRIS. But one problem with for example, sexually transmitted disease is that people are reluctant to get diagnosed. So going the extra step of taking the blood sample is something that one could convince them of if there's already the non-invasive signs showing that they do need to find out what is wrong. So NMR is something that we started working on, but ultimately we would need to find, as you point out, that's an expensive technique. So we would hope to find something less expensive, but non-invasive.
May I respond to that too? We have in QB3, we actually have a magnetic resonance spectroscopy for humans. Can look at 3 Tesla and 7 Tesla. There's only a few 7 Tesla MRI machines in the country. It's very expensive to use, but in fact, what the major advantage of them is not to use them for routine screening, but for following clinical trials, right? So, for example, the magnetic resonance spectroscopy, by looking at the ratio of 2 metabolites, is really a much better mechanism for telling what is a tumor and what is not a tumor. Like, normal magnetic resonance imaging just looks at mainly scar tissue, whereas magnetic resonance spectroscopy looks at metabolite ratios and gives it looks really at the metastatic tissue, the living stuff that you want to catch. And because the resolution at 7 Tesla gets up to being 100 microns, you can get the limits of a tumor with tremendous accuracy. The advantage of that, of course, part for neurosurgery, but also if you're looking at a drug and you want to see very quickly whether the drug is having any effect on shrinking the tumor, the better your size resolution is, the better it is. So it's a very powerful technique in conjunction with clinical trials, but I agree it's never going to be very useful for routine testing.
Also, there exist small MRI machines specifically designed for imaging animals, and as far as I know, he's doing experiments on mice. So and you can get much higher resolution. You see, there is this trade-off between before you bake somebody and get the right resolution. So, okay, go ahead, please.
May I? Go ahead. That's a very good point. One of the things that QB3 has to do is interact with industry, and we're supposed to be benefiting the California life sciences industries. In the last year, 9 months I've been doing this job, talking to the various people, CEOs and so on, of major biotech companies, the thing that they see as most limiting in their interaction, particularly with University of California, is the nature of our IP policies. And so what we are doing to try and, since that's the major problem, we're putting our energies really into solving that one first. So with Genentech and Amgen, we're working on a blanket agreement that will cover all investigators on the institution, so that the investigators, their researchers and our researchers can get together and work and not have to worry about IP. They just tick off various things on the form. This will be a big step forward if we can do it. And we think if we can get our 3 universities to agree to do this, then we can put pressure on the other campuses of the University of California to follow along.
Any other questions? Tom Khalil, you had a question at one time, and I shut you up.
My question was for the IBM representative, which is
Dr. Spellmeyer.
what is all this technology going to do to the current way that health insurance works, given that it's all about pooling of risk, and this is about measuring risk at the level of the individual?
That is it's a very good question. We don't know. It is entirely possible that as the insurance industry changes, and in fact is changing rather dramatically even now, that aggregating data in a different way and looking at risks or looking at risk pools as aggregated from a different way could be a rather dramatic change in healthcare, health insurance. I don't know if people are aware of this, but the health insurance industry actually is under a very interesting financial dilemma, and that is as fewer and fewer small and medium businesses and fewer large businesses cover the total cost of insurance, people are choosing not to be insured, and that's one of the main reasons why the rise of the number of uninsured goes up. And so health insurance companies are starting to look at individual policies. Costco is selling these. It's very interesting dynamics that are happening. And so the insurance industry is dramatically changing even as we speak, and we have no idea how it might change.
Thank you very much. Any other question? Oh, yeah. Jim, yeah, please.
One topic that hasn't come up is HIPAA and Health Information Portability and Something Act. And it's, every time I go near medical records, and I'm a database guy, every time I go near medical records, I worry about the rules that specify that fundamentally every medical record comes with a long contract of where it came from and what you can do with it. And almost every question that somebody wants to ask that's unanticipated has to be either allowed by that contract or not. And I'm not sure what we can do about HIPAA, but it's a very complicated law. It's about that thick. Everything that we want to do in the health area is prescribed by that. The flip side is if we build any medical instruments, we have incredible liability.
Yep.
And even doing experiments, you have this liability. And so these two things, frankly, scare me away from this field. And I'm wondering how you folks operate, because I've kind of shied away from this area because of those two things.
Anybody wants to answer? I can tell you, Jim, that when we started to do these experiments on elderly people with the force sensor with my students, I had to sign my life off in order to be allowed to do that. And these sensors are non-intrusive and extremely benign, and yet I was under tremendous scrutiny, and thanks to Mrs. Vicky Lucas, I got the permission from University of Berkeley, but only until June. After June, I have to apply for another permission, and so yes.
You're absolutely right. HIPAA is a long, complex law, and I am not expert on it, but I'll answer it from the perspective of a person who sits on the board of directors of a health organization and has had to have some working familiarity with it. With respect to patient care provided in physicians' offices or in hospitals, I think HIPAA has been very helpful in clarifying sort of what the objectives are in terms of accountability, portability, and privacy. And for the most part, just common sense adjustments have been satisfactory in terms of meeting HIPAA's requirements. And in terms of electronic medical records, I think probably it is easier to meet HIPAA requirements than it is with a paper medical record. If any of you have ever spent any time around your physician's office, you have seen stacks of medical records, and they are sitting on a counter. You see the receptionist calling out patients' names. You might see them throwing a few records into the trash can, which wind up in the bin in the back, and there are people who go through bins next to doctors' offices routinely looking for Social Security numbers. So probably electronic medical records make it easier to protect patient information, what's called protected health information, than does the paper medical record. When you get into some of the issues that have been discussed today regarding wireless transmission of information That's an area I'm really not expert in, but HIPAA does require that those be clearly protected and encoded in such a way that they cannot be intercepted and used by anyone. Is that helpful? There's actually a wonderful website. If you want to go to ahrq.gov, you can do a search for HIPAA, and there's a fact sheet, frequently asked questions sheet, which is the best single source of information for non-specialists on HIPAA I've ever seen. It's really very good.
I was actually Executive Vice Chancellor of UCSF when the HIPAA regulations came in, and I agree that they were a nightmare, the amount of time that everyone took was taken up. But I think one of the things is one always wants to have regulation on other people's industry and then squeal when people put it on your own, right? So that's just what happens. And I think the reason it came in is because some people really misused clinical information. I think the lesson to all of us is that we've got to really restrain our cowboys. It's a few cowboys in all of our professions that do things wrong and make all the rest of us suffer. And we're all suffering from the few cowboys in the medical profession that misuse records.
So the partnership that Shankar talked about is with Finland and Denmark, who presumably have very different rules, but maybe that and a lot of the problems we solve are completely international. Maybe the benefits would be felt somewhere else first. Can you address that?
Do you want me to take that? Or
Yeah.
I send the question back to you, Riku, and if you want to talk about Finland.
I'm Riku Mäkelä from National Technology Agency of Finland. And about the question, so we have differences in our systems in different nations, and just like David Frailer told in one of his speeches in the beginning of this year that he had been talking with UK Minister of Health or something like that, and they had found out that they cannot learn that much from each other in a system level if you think about the whole healthcare system. But there's so much to do in technology level and applications, and for example, if you take chronic diseases and management of that, so there are a lot of things that you can learn from each other, and also things that you can create kind of global solutions that will be good for business for big corporates who are trying to attack global markets and so on.
And
thank you very much.
If I could
please,
add, the global issue in transmitting electronic health records is in fact going to be a big issue, right? I mean, most of us are looking locally right now, but ultimately it will be a global issue. One of the research programs that we are working on with the people who are actually selling this today is to transmit electronic health records from sites in the US to Israel and back. Specifically using international standards, accepted HL7 standards for how to do that, and keeping track of the privacy and security, et cetera. So it's a core issue that has to be dealt with.
Any other burning questions? Well, in this case, if there is nothing, yeah, please, yeah, quick.
Quick. Is this on? Yes. Paul Wright from CITRIS. I mean, I've really enjoyed the presentation, but several of the questions all come together about how CITRIS is going to try and funnel these various issues down. We've got sort of device issues. We have huge healthcare policy and legalization issues. And I just wonder, as a group, how do we go forward and funnel it down? Or just Shankar, on our famous diagram with the funnels at each end, we need to do something in the middle there to cover this huge spectrum that we've heard about today. So maybe, Rujna, that's a question to you, which is how do we get traction within CITRIS in such a complex topic, which is probably our most complex of topics if we build in all the business issues, the insurance issues, and the gigantic public policy issues. So, Rujna, that's my question to you.
Yeah, thank you. Well, as you very well know, you don't tell Berkeley faculty or for that matter, any faculty anything. I mean, they are Miss and Mr. Independent, so one has to start with that premise. At the same time, there are several of us who are excited, who are interested in doing things that are not only intellectually challenging, but also they have utility. And what better utility than help healthcare. So the technologists, as I am one of them, will continue developing technologies as we go. But we also are committed to test this technology in a real-world environment. And once you make that premise, you cannot avoid all these other aspects as were presented in this panel. So I believe that CITRIS and I and few others, Shankar and so forth, we are deeply committed to keep this alliance together and periodically consult and work with other colleagues who are social scientists, economists, and providers, whether our technology makes any sense.
So if I can just jump in a little bit, this is a very complicated space, but, I think that maybe things don't have to be all that complicated. I mean, there is a role for technologists to develop technology. There is an overlay of legislation, there's an overlay of compliance with legislation, there's an overlay of liability. But all of those are present in other societal scale systems. There's certainly that in the automotive and the transportation sector as well. Now, I think that, to be pragmatic, I really think the kinds of things that will happen in CITRIS are, one is this notion of wireless network embedded systems, and I think that'll be a tech push activity it'll be relatively less invasive at the outset, which is, just monitoring activity, for which FDA and other certification rules are not as onerous as those which involve some more invasive technologies. And of course then security, privacy, the ability to comply with the HIPAA or with other legislation that's coming along. I think we'll be able to do something in terms of making it easier to comply, and possibly write amicus briefs about how legislation could be streamlined, should be streamlined, also as part of the CITRIS mission. The other thing about the exquisite detection, I think that too is a technology push, and I think Reg alluded to this. It's 10 millimeters today, it's a droplet of blood, it's just a smear tomorrow. So that, I think, is also an agenda that's going to march along, and then the question about, but I think more generally, I think if we harken back at this, all analogies to the internet are not fantastic, but really the key to the internet was this sort of the narrow waist, so this is a different picture, this is the hourglass picture. If you have the middleware, which is open and non-proprietary, it allows for a variety of applications and a variety of different physical devices to all work together. So the issue, I think, in a lot of the medical device industry is that it's in fact vertically integrated. And if one were to think about a big difference that we might make, that CITRIS might make, it is to really try to get a hold of that narrow-waisted middle and to make available open standards there so as to allow for multiple kinds of healthcare providers, multiple kinds of insurance companies to use multiple different kinds of technologies in between. And just judging from what we've been talking about, and I think all major companies have a healthcare division, and they're also thinking about their own sort of strategic view. I think there's a lot of support for being able to sort of free up this middle and to make that open. And I think maybe CITRIS and QB3 can help in that one piece,
Horizontal integration. Thank you very much.